Hi, everyone. Welcome to Mental Health Trauma-Informed Care for Navigators. This is part of our Navigator Focus series. Welcome. We're going to wait a little bit while we wait for more people to join. And while you join, please let us know your name and where you're from, what site you're from. We love to see who's with us and who's sharing our information today. So again, please let us know. There's Carrie from Marshall. Hello, Tammy, welcome. We have Antioch, BART programs. Welcome, Martha from Whittier, Southern California. Modesto. Oh, wow, everybody's logging. We have Ontario, Canada. Wow, that's really, I think that's the farthest one so far. Ontario, Canada, welcome. Ridgecrest, Santa Cruz, Karina from Methodist. Hey, Karina, how's it going? Oscar from Glendale. He was just here shadowing me at Pomona. Again, my name is Sherry Cisneros, and I'm the director of the Navigator program for California Bridge. You might notice I'm in a different surrounding. I still moonlight here at Pomona Valley Hospital. Some of you sons have had a chance to come and shadow me. So I'm live from Pomona today. So welcome everyone. We're going to kind of get started in a few minutes, probably a minute or two. But we're so happy that you can join us. We are really very excited to have the authors of our trauma-informed care if you've been on our website. So this is really, we've tried to make this happen with Edward and Triveni for a while now. So I'm really glad that this finally came to fruition. So let's get started. We share our information through Creative Commons, that's the licensing. And we just want to say welcome. And make sure that for the best experience today, you connect your computer to a power outlet, close the necessary windows, use the chat for questions, and make sure it's addressed to everyone. What happens is you send your question to me or the panel, and then somebody else has the same question. So if you put in a question or type it in the chat, make sure that you address it to everyone. And we will have closed captions available throughout the session. And this session, as you know, is being recorded. So real basically, I always like to go over what our goal is. You guys know what the California Bridge goal is, universal access to addiction treatment in all hospital emergency departments. As you can see, I love this chart, you guys. We're on our way. I mean, when you look back to the first 30 in June of 2019, we were at 29, and now we're heading in the right direction. I believe we're on over 180 at this point in time, and our goal for our California Bridge team is take over California with 330 hospitals. So we're really excited that this just keeps growing, this movement, and you are the big change agents for this movement. So we're really proud of you guys. Our bridge model, very simple, low barrier treatment. Come to the ED, tell us you're going through withdrawal, and guess what you're going to get? Buprenorphine. And you're going to get connected to a wonderful and fabulous navigator in the emergency room who is also reducing harm to our patients and promoting a culture of safety, right? A culture of harm reduction. So real easy, three focuses of our bridge model, very simple, and you guys are all part of all of those focuses. So our objectives, they are listed for today. That's our agenda. We're just talking about trauma-informed care. So just to let you know, we have a poll that we wanted to get started. So if you want to do that poll, are we gonna put it in? Here we go. So our first poll today is, are you familiar with terms trauma-informed care and adverse child experiences? Yes, you're knowledgeable. Yeah, kind of, but want to learn more. Or no, that is why I'm here today. We kind of just want to know where you're at, you guys. So let us know. We're going to take a minute to get you guys in that poll. We'll take a few minutes. And wow, we had two. So here is the answers. Are you familiar with the term? Yes, 42%. Yes, somewhat, 44%. That's why you're here. I love that. No, that is why you're here today. Great. So some of you, this might be a review, but for some of you, this is going to be some great information. And then just in general, have you experienced a childhood experience yourself? At adverse child, yes, 75%. So these, 90% of clients in public behavioral healthcare settings report that they have experienced trauma. So we're not quite 90, but we're close there at 75. So let's get started. It is my pleasure to introduce the authors of our trauma-informed care for opioid use disorder. We have the tool on the website. If you have not seen it, it is written and it's wonderful. The case study that's being presented today is on our website. And the goal is improving the success of medication for opioid use disorder by integrating trauma-informed approaches. It is my pleasure, once again, Triveni, DeFries, and Edward Machtinger.
Hi, everybody. I think we will quickly introduce ourselves. I'm Triveni DeFries, so I'm a physician. I'm an internal medicine and addiction medicine physician. I'm based at San Francisco General Hospital, where I do primary care and I work on our inpatient addiction consult service. I'm also a consultant on the substance use swarm line, and I actually recognize several of your names in the list of participants from that. So thank you so much for having me, and I'll pass it to my co-presenter here.
Hi, everyone. My name is Eddie Machtinger. I'm a primary care adult HIV doctor. I direct our women's HIV program at the University of California, San Francisco. I also direct our Center to Advance Trauma-Informed Healthcare. Thanks so much for having us.
So we'll just start with a little bit of background about trauma-informed care. And the first point that we want to make is that childhood traumas, which are also known as adverse childhood experiences or ACEs, are incredibly common and are especially common amongst your patients, those with substance use disorders. And there's research now that shows that the more childhood trauma someone has, the more likely it is that they will have an issue with unhealthy substance use as an adult. So the risk of having a substance use disorder, it more than doubles for each additional ACE that a person has. And so for people who have experienced like 4 or more ACEs, they have more than 10 times the risk of having problematic substance use compared to somebody without any ACEs. And understanding that patients with opioid use disorder have probably experienced significant trauma is one of the first steps in providing trauma-informed care. And this is really important because understanding trauma-informed care can lead to, 1, more successful treatment with medications for opioid use disorder, which is your job, and 2, more successful identification and treatment of other trauma-related conditions like co-occurring mental illness or unhealthy use of other substances or violence like intimate partner violence. And knowing about these other conditions in people's lives can really help you to arrange treatment for them and help you to ultimately then be more successful in treating their opioid use disorder and saving lives. So what exactly is trauma-informed care? Here's a definition to use. It's a patient-centered approach that helps providers understand that many physical and mental health problems like opioid use disorder come from having experienced trauma and from coping with that trauma and the difficult feelings that result from it. And there's 6 principles of trauma-informed care that have been laid out, and they're listed here: safety, trustworthiness, transparency and collaboration, empowerment, cultural humility and responsiveness, and resiliency and recovery. But what does that really mean? So let's go to the next slide. And Eddie, can you tell us, in practice, how do you actually operationalize trauma-informed care and these principles?
Yeah, thanks. And I just want to go back to something you said about the definition of trauma-informed care. I think for me, trauma-informed care just is a way of demystifying my patients, understanding them. Like, why is somebody yelling at me or yelling at the receptionist? Why is somebody dissociating, like disappearing from the conversation I'm having with them? Why are they so reactive? Why are they addicted to crack cocaine? Why are they struggling with quitting smoking, even though they have lung disease? Like, unless I understand that that is because a lot of really intense things have happened to them, and that they haven't had the protective factors in their lives to buffer those things from happening to them. That these situations and behaviors are the result of trauma. I then take that personally, and I might get reactive, or my receptionist or the nurses might get reactive. Where if you understand that this is somebody who is coping with really intense trauma and probably has post-traumatic stress disorder, and that these behaviors, being reactive, being dissociative, and use are from that, I just wouldn't understand them. And understanding that lets me be much more patient with them and much more compassionate and not take things so personally. So in terms of the values, like, I tend to condense the trauma-informed values into 2 things: safety and connection. And by safety, I mean, I want to make sure that my primary intention is that that person is safe in the world. So is there anything that's imminently going to hurt or kill them? And then I want them to feel safe with me, so that they can trust me and develop a connection with me. Because it's only in that way, if they feel safe and connected to me, that they can reveal themselves to me. Because what they'll reveal, tends to be so much more important than what I've walked into that room on my checklist of things to do. I hope that answers your question. That was a lot.
And we'll get into it more as we work through an example in a case.
Yeah. Ultimately, I guess what I'm trying to express is that trauma-informed care really makes practice and connection with patients easier and better and kind of more enjoyable, because it helps you understand kind of who you are and who they are in the interaction you're having.
Okay, so now it's Navigator poll time again. I'm going to interject in just a quick second with what our panel has said today about safety and connection. How can you relay safety and connection in the healthcare setting? Provide a safe environment, offer harm reduction techniques, supplies, and support patients in preventing overdose. Listen more than you speak, or all of the above. Let us know. We're going to give you a few minutes. We like it interactive. And again, if you have questions, you can put them in the chat or wait until the end. There will be some time for question and answers. But we just like to engage you guys and kind of see how you're feeling about this. Is this something you guys are doing already with safety and connection? Everybody's doing all of the above, you guys. So we've got a great audience. All right.
So Eddie, you told us a little bit about what trauma-informed care means to you on the ground. What does it not mean? What is trauma-informed care not?
Well, Specifically, it doesn't mean that you have to take a very detailed trauma history on the patients that you're working with. That trauma history can be addressed by therapists or social workers with expertise in trauma, or may emerge from your conversations with them. I think when you're working with, I work with women of color living with HIV, 40% of whom use crack, methamphetamine, or heroin. I can assume that they have experienced very intensive individual, family, community, and historic trauma. And so I don't have to take that history from them to make some basic assumptions that their substance use is driven by coping with the impacts of all of that trauma, and that my job is to help them kind of feel better about themselves, help reduce that trauma if I can, and just make that, I guess most importantly, make that initial encounter feel safe for them and not be traumatizing to them, like to love them and to accept them and to have that actually be part of the therapy we're providing. But I think to your question, I think a lot of people think trauma-informed care means asking specific questions about past trauma. And for many populations, especially the one we're talking about here, it does not.
And the word trauma is in trauma-informed care, but I think we also want to make the point that trauma-informed care does not only focus on trauma.
I think that's right. I think I mentioned this a little earlier. Trauma alone doesn't define somebody. It's really the balance between trauma, various forms of difficult things in life, and the protective factors that you have in life. An adult that is present and sees you, a church group that you're part of, a school that you're part of, close friends that you can talk to. And it's that balance between trauma and protective factors that lead, or that imbalance that leads to substance use and other diseases. What's so helpful about focusing on strengths when you talk to patients is when they tell you about some of these strengths, like relationships or groups that they're part of, you can use those as ways to support them further in their recovery from substance use.
Exactly.
Talk about them, emphasize them, encourage them to really access those people and areas in their life that they get support from, instead of just talking about abstinence and drugs.
Great. So next we're going to actually get into a case. Great. So the purpose of going through a case together is really to provide an actual example, of a patient that you might see in an ED, and to talk through how to put these trauma-informed values and practices to work for you with clients when you are starting or continuing medications for opioid use disorder. And the case that we're going to outline here, it's really not to exemplify and show you exactly what to say or what words to use, but it's really more to shed light on just how to be with patients. And you're going to hear Eddie and I kind of go back and forth and discuss our responses together. So let's get into the first part of the case. There will be 4 different parts. So part 1, we are in the emergency department, and we're going to talk about a patient named Layla. And Layla is a 60-year-old woman. She presents to the ED with abdominal pain, vomiting, muscle aches, and she's presented to the same ED with similar symptoms several times now. She's heard staff refer to her as a frequent flyer or pain-seeking when she presents with these symptoms and has anxiety or pain. And in the ED, she's really uncomfortable and she's irritable. She's given some anti-nausea medications and ibuprofen. And she just doesn't want to leave the ED, and there's that pressure. The providers are frustrated. They want to discharge her. So the provider sees in the chart that Layla has been prescribed oxycodone by her primary care provider for chronic pain in the past, and assesses the patient for opioid withdrawal in the ED. Also finds that the chart describes, several prior concerns for opioid use disorder. And so this provider, who happens to be a white identifying cisgender male, sits down, speaks with Layla for a few minutes, and learns a bit more about her background. Layla herself identifies as African American. She's a cisgender woman. She works as a childcare provider and lives with her older 2 children and her male partner. And there's a lot that the provider doesn't know about her when he sits down with her. What he doesn't know is that Layla grew up in a household where she actually witnessed quite a bit of violence. She had a parent with a substance use disorder. She had been separated from her own mother for periods of time, even had experienced some homelessness as an adolescent. And recently her mother had died of cancer, and Layla had a very difficult experience with the healthcare system during that. Currently, her home situation, it feels unsafe. She's had some verbal and at times physical violence from her current male partner. He uses cocaine. And for the last year, she's been buying and snorting pain pills. And so she often ends up visiting the ED when she runs out of those pills. And she doesn't want her children or partner to see her unwell, so she comes to the ED looking like this. So hearing that, Eddie, why don't you go ahead and start, like, hearing that story, what is your initial reflection and approach to this patient in the ED?
Well, I just can't overemphasize enough that patients like this, when they come in for care, expect to be treated poorly. I think they not only expect to be treated poorly, that they expect to be disliked or even hated. Like, it's so stigmatizing to be using substances. And then you're really only presenting to an emergency room if you're absolutely desperately in need, because they're just so scared of coming in because of the judgment and the mistreatment that they expect and often receive. And so for me, I think the most important thing is to go back to safety and connection and think, what in the world is going to help establish rapport with that patient right away? And for me, it's just presence, a little humor, and love. Like, for me, going into that patient, I think so many people are stressed in the ER, the doctors in particular, and the nurses often, and that patient is a problem. And they're acting like that patient is a problem. So for me, the goal is to not further traumatize that patient by treating them as a problem, and instead go in there and treat them like a human being who I'm actually really interested in and may even like and even love. And so I would go in there and say, introduce myself, try to acknowledge that this must be really, really, really hard for them. Try to find something to joke around with. I mean, sometimes I just say one positive thing. Like, I always say one positive thing. Like, that's a really awesome tracksuit. Like, where in the world did you get that tracksuit? Oh my God. And I'm not making it up. Like, I try to find one positive thing to say as an icebreaker. And then if there's any opportunity for humor, touch, play, anything that humanizes that situation so that that person can know that you're experiencing them as a person and not a problem. The first step of trauma-informed care is to stop traumatizing people. And many of these environments are traumatizing. So anything you can do in your role to have patients feel accepted and loved and not stigmatized is trauma-informed care at its most important.
Yeah. And I think hearing that background about Layla, there's so much that this ER doctor didn't even know about her, that led her to present the way that she presents in the ER. And so we can recognize the impact of trauma, of her traumatic history. We can assume it. We know that it's there. And then we can move to some best practices that Eddie started to lay out. So if you go to the next slide, and we have these best practices listed in this slide set as a reference for you, but absolutely we can reassure Layla that she'll be treated and helped in the ER, and that we're going to make her feel better before we ask her to do any sort of long interview or intake with us. And we can ask her permission to talk about her substance use before we jump into it. We can assume fear in the ED. Like Eddie said, what a difficult environment, and also an environment where even healthcare providers are experiencing their own trauma and are reacting in their own ways, feeling frustrated and helpless. So what are some best practices that you all are using? You're doing this every day. Please feel free to share them in the chat. And we'll keep going with the case, but feel free to chime in. So second part of our case here, we're still in the ED, and the ED provider actually asks Layla, after talking with her more, if it would be okay to talk about her use of opioid pills, asks permission. And she gives it, and with the information from that discussion, the provider actually is able to go ahead and diagnose a moderate to severe opioid use disorder. And Layla ends up getting a dose of buprenorphine in the ER and feels a lot more comfortable. She feels better. She's in a better place to talk. And she's interested in talking with you, with a navigator. So the navigator, helps her set up some follow-up from the ER the next day, actually in a bridge clinic. But Layla mentions that she is scared to go home from the ER that night because her male partner is there. So with that kind of comment and hesitation, Eddie, how do you respond?
Well, it's part of the safety and connection. So I really emphasize the personal safety, like her feeling safe with me and then connected with me. But I think this is just an example of how immediate safety for our clients may refer to things that aren't initially on our checklist. And it turns out that she, is in a probably experiencing a domestic violence situation. And it could be that this domestic violence situation is actually more dangerous to her health than her substance use, and is certainly something that is contributing or a factor in her substance use. So this is something that requires, pausing, and the first emotion that comes up is just being sad, honestly, and then kind of scared for her. And so I think it'd be acknowledging that domestic violence can lead to death, and that, or serious harm, and that this now needs to be up-leveled to the social work staff in the emergency room for an assessment and linkage to domestic violence agencies. There's a 24-hour domestic violence service line nationally. There's oftentimes local 24-hour domestic violence service lines where social workers and other providers and you can call and get guidance about how to help this person assess risk and then access housing or restraining orders from the police. I think just in general, it's a moment to pause, not get overwhelmed, just express how sorry you are that they're experiencing that, and how just appreciative you are that they've trusted you to reveal that part of their experience, and that that's something that you want to know about and that you're going to do your best to help them with.
The next slide.
Hey, Triveni, I wanted to address, we have some best practices, and we have a few, and they're really good. So I wanted to take the time before we move forward. Latoya mentions noticing their tattoos, hair, clothing. These are the way they express themselves. So I show that I see them. That's huge, because it is self-expression. I love that one. Marianne types in asking questions unrelated to their trauma. Or the advice of Edward, kind of an icebreaker, right? Totally helping them to remember the things they are connected or that they love. And then other people write down elbow bumps. Yeah, in this age of COVID, right? No handshaking anymore. Dressing in non-clinical attire. Yeah, that could be triggering. Definitely people in scrubs, right? Sitting at eye level, harm reduction, offering harm reduction. Just to show that I'm an ally. Yes, definitely you're in their team. Offer a piece of candy. I like that one, right? Because usually if they're coming down off something, the candy can be really good. So I like that. And I let them know I'm honored that they shared their experience. And we have a lot for candy. I think a lot of people, we're on to something here, you guys. That's definitely got to add to that best practice, because there's a lot of you using that sugar, right? Put you in a good mood. All right. I'm going to let you go ahead. They keep coming in, but candy is the winner, you guys.
I couldn't agree more with the candy. And it's no doubt, right? It makes sense that you've used all those things. And so people are going to reveal to you these vulnerabilities. You know, they're going to reveal to you about these relationships or intimate partner violence. And when that happens, you'll be prepared, right? And I think using some of what Eddie just said, I just want to highlight two pieces of that. One is that by using those statements of empathy and validation, you know, making Layla in this case feel respected and safe, it's going to open the door to these conversations. And when the conversation moves towards something like intimate partner violence, just really want to flag how important it is to do that in a private space. And secondly, want to flag that when you're talking to them in this incredible non-judgmental way, it's going to really pave the way for future discussions, but it's unlikely to really change, you know, Layla's relationship in this day, in this moment. It's really unlikely that after one meeting in the ER, you know, Layla is going to leave her partner. But what it might do is provide for a trusting relationship, and where Layla feels open to talking about her plans and her stressors over time. The other piece around best practices for when IPV comes up is really just being equipped with your knowledge and your local resources. So maybe that is something that you're very familiar with at your particular local institution. If you're not, take the opportunity to learn those resources of what's available. And if you're not sure, the national resources that Eddie mentioned, the National Domestic Violence Hotline and Suicide Prevention Hotline, are awesome resources, you know, to even have saved in your cell phone so that you're ready when these conversations come up. And then also just want to flag that when they do come up, there are some reporting requirements to know about in California. You as a son are not a mandated reporter, but clinicians would be if there's evidence of physical harm. And so it's something to tell patients before they start talking to you about what the reporting requirements are. And then also this is something to elevate, right? This is something to elevate to the clinician or social worker in the ER when they come up. I see a chat that from Rebecca Harris. I thought we were mandated reporters. This is a really good point of clarification, and also something that actually there's some policy debate around in the state at the moment. But to my knowledge, it's clinicians who are mandated reporters when there's evidence of physical harm. Okay, and certified substance use counselors. Okay, and Sherry, anything you want to add around specifically the substance use navigator role here?
You know what? Yes, I do. I mean, I think the best thing is to ask your supervisor if you're required, because it would be in your policy. So definitely, you know, reach out to your supervisor is the best suggestion. If you do have a license, such as a certified substance use counselor, you would be required. That's mandated. However, as a substance use navigator, you may be required to report to a supervisor, to a clinician, and they would fill out the forms, or the social worker. So that's what we said, really follow up with your institution and that recording practices.
Great. Glad that we're talking about this. So let's move to the next part of our case. This is the third part. Layla is now coming back. She's coming back for a visit at the Bridge Clinic. She's been discharged from the ED. She's talked with you and she showed up. She honestly was really ambivalent about whether to come, but you were non-judgmental. You really listened and you really gave her the ability, the information to follow up in a really detailed way, where to show up, when to show up. And what really helped is that the clinic that you sent her to had open access hours. It didn't require an appointment, and she could just actually come in when it was convenient the next day. So she was also feeling better physically because she had started buprenorphine. She had some fears about coming back to the clinic. She was fearful that the clinic would do a urine drug screen, and that they might take away her buprenorphine if they found out that she had also used cocaine. She hadn't told anybody this, but previously she had actually tried methadone at a methadone clinic at an opioid treatment program. And she was confronted about her cocaine use there, and it didn't go well, and she left. So she just wasn't sure if she would be comfortable again in a program. She never really liked doctor's offices. She didn't like how she had to take off her clothes there. She didn't like being asked personal questions. She really didn't like it when she had a male provider who would do an exam. It just made her feel really uncomfortable, especially after her mom's bad experiences with cancer treatment recently. So she's at the door, she's coming to Bridge Clinic. She has all these hesitations inside. Eddie, what can we do today in the clinic to help connect with her?
I feel like I sound like a broken record, but I think, my comment about always saying something nice came from a substance using patient who just once told me, just like, please just say something nice to me. And so I think, again, it comes down to welcoming her, acknowledging, just, saying something really nice to her, trying to break the ice, trying to be kind of fun and playful with her, even though the situation is very tense for her. And, communicate to her in non-verbally and verbally that you're there for her. And that you understand that this is very hard for her. And then I think I would probably directly elicit from her, what her goals are for the meeting, and then also what her fears are about coming in today, so that you could address those and recognize those head on, because you may not really realize that she is worried about something that is actually not reality based, because your clinic might not have those kind of policies that would be punitive for, for having other substances in a drug screen, or you might not even be drug screening that day.
Right, like if we don't anticipate and address her most immediate fear, which is about the urine drug screen, we actually may not be able to retain her at the Bridge Clinic. And so we can be really transparent about our role and like how we use urine drug screens and explain that to her. I
think, Triveni, it's about taking, for me, it's just about taking an extra minute to not be so directive. Like oftentimes when people come into clinic, they you track them into like a little machine. And I think taking a minute to just be present with that person, maybe not even say anything for a second, to joke around with them, to be nice to them, and to check in with them about their hopes and fears for the visit, without your hand on the doorknob, with you sitting next to them, communicating to them that you really want to hear them. And oftentimes that takes like 2 minutes, and changes fundamentally the whole kind of emotional experience and actually what you end up focusing on.
The other thing that, we've brought up a couple of times is the clinic environment itself, just like the ER, can be traumatizing to patients. And, Layla had expressed that, right, around like the physical exam and taking off her clothes and things like that. What are some things that your clinic, Eddie, has done to actually try to optimize your environment to address patients, physical and emotional safety when they're there?
Yeah, a lot of times people think about trauma-informed care, the environment of trauma-informed care principally is the physical environment, like fish tanks and teddy bears and like things like that. I'm kind of kidding, but I'm not. Like that's what people think of. But the environment of care is really mostly the attitude of care. And so, we work with our front desk staff to be kind of flexible and welcoming. So oftentimes people come in late. And so having that person at the front desk say, hey, I'm sure that there's a million things that got in the way of you coming late. Let me see if I can help you get what you need today. Or if the person comes in and they're kind of reactive, to help not be reactive back. So if they're, yelling or they're butting in line or they're acting strangely, to walk around from the back of the front desk and say, hey, come on over here. Let me talk to you in private. Like, is there anything I can do to, help you feel better? It's how do you not be an authoritarian place in a society where a lot of people of color in particular have experienced institutions like healthcare and like corrections as being very punitive and authoritarian. How do we create an atmosphere that's not authoritarian? And so that's a lot to say. That's a lot about the attitude. Sometimes you can't control your physical environment individually, like you can't make your clinic be in a wonderful space, but you can try to find private spaces within your space, and you yourself can really make a big difference, overcoming some of that hierarchy and kind of punitive authoritarian kind of vibe. And instead, because that's what they're assuming they're going to experience, they are assuming that people are going to treat them badly. And when you treat them well, and are sweet with them, it breaks down a lot of defenses. I hate going to the doctor myself. I just assume, and I'm like a white doctor. I assume that my doctor isn't going to care about me, isn't going to know what's wrong, is going to tell me something scary, is going to blow me off. And that's me, and let alone somebody who is coming in with a stigmatized experience. And as a cultural, facing a lot of different, bias and stigma.
Let's go to the next slide. Just, to be aware of what in the clinic environment, kind of brainstorm about what can make it safe and quiet and what can actually be really triggering to patients. Things like security guards, police activity, alarms. And I think, Sherry, you have a poll here for people to sort of reflect on their own clinical environment.
Yeah, we have a next poll. Do you have a quiet and safe place to talk to your patients? The emergency room is wild and crazy, and sometimes our patients are discharged right from the emergency room and they're just waiting to talk to you. Do you have a quiet and safe place to talk to your patients? Yes, no, but I'm working on creating one. This is one best practice we strongly suggest. 9999. We're going to wait a few minutes for people to poll, and so bear with us. Let's see. I have the results. So yes, 42%, no, 32%, and 26% no, but I'm working on creating one. Absolutely, you guys. And I strongly suggest, having a place out of the chaos. I know sometimes it's impossible, and you guys are addressing this in the lobby. But make sure, one thing I always suggest, if you do have to talk to somebody in the lobby, I always kind of bring them to a corner or bring them to a door and make an attempt to make a safe little space for me and whoever I'm talking with. So that way it's one-to-one and not one to the whole lobby, right? You're just standing, oh, who's, screaming the name. So just, try to make that, even if you don't have an environment. I understand, for your hospital, you may have to work on that, but how can you make a safe and quiet environment and be creative? Like I said, I sometimes I have to go in there and I just kind of bring them to the door and stand a little closer and just say, hey, I'm here to help. I know it's really busy in here. As soon as we get a place to talk, I'll talk with you where it's a little more quiet and private. And sometimes it's outside. I'll be honest, you got to make what works. So again, anybody, if you want to put in there what you do to provide a safe and quiet environment in the chat, we would love to hear your answers and help some of our substance use navigators that do not have that safe and quiet environment. Yeah, I hear another one, go outside. So definitely, thanks for your answers.
Great. I'm glad you all get the chance to share those pearls from your own environments. While you're doing that, I'll get into our last part of the case. So it's been a couple weeks and we're back at the Bridge Clinic. Layla has continued to work with the clinic. She's actually stabilized on a daily dose of buprenorphine. She really has appreciated those open access hours. She's even appreciated that some of her visits she could do over the phone. So she's been able to make it actually weekly. She's felt a lot more comfortable, largely in part because she first got to talk with you, with a navigator, and you shared some similar life experiences with her. She felt a lot more trustful with you than she did with the doctors. So she's been doing okay. And she even recently has been accompanied by her son to a few of her visits. So now that she's been feeling well for the last few weeks, she expresses to her doctor that she'd like to stop the buprenorphine. She doesn't want to be addicted to another opioid, and she's visiting the ED a lot less. So she thinks she's probably ready to stop. She has noticed she has time to take care of some of her personal finances and kind of urgent business that she needed to do to secure housing. She also, she's noticed that even though her partner continues to use cocaine, she's using a lot less cocaine since she stopped using the pain pills. Has a lot more energy, and she's even started attending church again on the weekends. So with that kind of success, and then also this piece about the next step, we're at a crossroads in her treatment at Bridge Clinic. And so how do we go from here? Eddie, let's first hear your reflections.
Well, one thing I would always take time to celebrate our successes. And I think, ask her what were the factors that led her to be able to be successful with her own goals of reducing her use and with navigating her relationship. Because I think the more we can support her to feel strong and successful and to acknowledge her strengths, the more she'll feel successful. And the more we know about the factors in her life that bring her strength and support, the more we can then, when things go wrong, as they often do, the more we can go back to that and say, hey, remember last time you said that, your friend Jackie was the one who really was there for you? Have you told her what's going on? Does she know? Can she come to the next appointment with you? So I think just acknowledging success and then asking her to maybe teach you back what was successful. I'm earnestly curious. Like when I see success in clinic with my patients, I really want to know how they did it, because it's oftentimes a mystery how people are successful. And I want to know for my next patient.
Yeah, I mean, Layla really articulated, like, she's drawing on church again. She's inviting her son into visits. Like, these are huge sources of community and family strength.
Yep, for sure.
And regarding this crossroads in her treatment, she's considering discontinuing buprenorphine, and this comes up, right? This comes up all the time. And, we could ask her, like, to explore that with us. And this is really where drawing on motivational interviewing is going to be very, very helpful in really letting Layla decide and give her the information, the options for her to make her next choice. If she's open to it, we could definitely explain here that when people continue buprenorphine, they're longer term, they're less likely to go back to using opioids. And we can help, because we understand other things about her life. We can help to troubleshoot, like, why is it hard to continue buprenorphine? Would it be helpful to switch to a monthly injectable buprenorphine? And would that help her to continue the medication and the treatment? So if we go to the next slide, just in summary, best practices here around how to collaborate with patients in decision-making really include guiding the patient with options rather than using a hierarchical, paternalistic type of approach, using motivational interviewing as our key tool, and allowing patients to make their own decisions about their medications. This brings us to the end of our case, actually. And we will have some time for questions, but I hope that this case that we outlined here, as I started, really got at just how to be with patients. And looking at the chat and hearing from you all, it shows how much experience you have and how much wisdom you have about how to do this. And so I just want to summarize quickly here what we've learned about a trauma-informed care approach today, which really starts with the understanding that a lot of illness and unhealthy behavior is related to experiences of significant trauma. And gosh, that's so common. 75% of us on this call today share that history. The practice of trauma-informed care starts with compassion, listening, and being present with people. And trauma-informed care helps to provide a foundation for these two key principles of safety and connection. And that's what opens the door for patients to be successful in their own goals. So we'll end there and take some questions.
Oh my gosh, that was so great. It was amazing, this discussion with the chat and integrating that with your presentation. I think we found it very useful. We have a couple more chats. I have one here from Tanya. Sometimes our patients want to leave the ER and smoke a cigarette, especially when they are sent in from a program. How do we handle this? How do you handle this? What would you suggest of the, when patients do this? You have to type in the chat. Our panelists, do you have any words of wisdom for Tanya? I just know personally, we allow our patients to go and smoke. I mean, it's better than discharging them and have to readmitting them. So, we'll let them go sometimes, especially if they are in a crisis mode and there's a long wait, right? That's usually the reason, is there's a long wait. Or as a navigator, you can try to fast track them and see if it can direct the care and guide them, so it'll be a little bit faster and fast track. So those are some of the things. Any other suggestions? I say go smoke. So, again, let us know in the chat. Another person puts, they've been following up with patients a lot on the phone after discharge. They created an ED discharge list, and they run every morning and call the patients to track them down to connect with when they are out of the ED. Sometimes that's a lot easier to talk to patients because they have time and they're not in that stressful environment that Triveni and Edward were talking about, that all those triggers and the security guards. And sometimes that's going to be your best conversation, is when they're not here in the emergency room. So you're definitely right. Camilla types in, I think language is so important for someone who uses a substance versus he is a drug addict, or tell me about your substance use, versus so you're addicted to fentanyl. I agree, definitely. Using destigmatizing language. And mandated reporters, I missed the certified are mandated. Okay, we will clarify that, definitely. I will put that probably on Slack and let me clarify, so in case those who missed it. And so Camilla also writes, correct in some instances, okay, for child abuse. We'll get you some solid information for that. Anything else, you guys? Any other questions for our authors? I really appreciate this. I mean, it sounds like our sons are on the road to dealing with trauma, and I love the fact that what it is not. We don't want to trigger them, you guys. That's a key point. And I think that's the point that I have been reassured with, is don't trigger our patients. They're already vulnerable. They're already in an environment where they need our help. And I do have one kind of final question, or if you guys want to give a final thought, is when you're talking with patients with trauma-informed care, is it okay to we mentioned family, and sometimes family is the one that's telling us about this trauma. I've had that a lot of times happen. It's the person that's bringing them in. How do you suggest that we go about talking with this trauma so as to not traumatize the patient?
Triveni, do you want to try?
So Sherry, you're saying that a patient comes in with family members, and the family members are giving you a lot of that history and that context that the patient might not be sharing with you.
Absolutely.
Yeah, I mean, I think it goes back a bit to the point that we made about what is not trauma-informed care. And we sort of talked about what can be seen as this universal precautions or universal education approach. We can assume, based on what we learned today, we can assume that that patient who came in with their family has a significant history of trauma, has experienced childhood adverse events. So assuming that, we can move forward with using the approaches we've talked about today, and the details that either the family members give us or the patient themselves gives us, they don't really necessarily change things too much. We need to use universal precautions and universal approaches for every single patient with substance use disorder, because we can just assume that they've experienced this traumatic history.
Yeah, and I would say the patient is your patient, and so you may hear things from family members, and you can acknowledge those things. But I would always turn the conversation back to the patient to see what they're ready to talk about and disclose, and not follow up on things from family members that that were brought up, and again, emphasizing, especially when patients come in with partners, to always create some alone time with that patient, because really, really, really controlling partners will do everything possible to be in the room with that patient at all times, including convincing the patient to tell you that. And so if you can kind of normalize, hey, every time I see somebody, I always meet with them alone. Nothing personal at all. Can I ask you to step out for a couple of minutes, and just make sure that you have that alone moment with that patient. Every so often that really makes a humongous difference, and they reveal something to you that they would never say in front of their partner or family member. And that includes family members too.
That's great. That is awesome. I really hope our navigators take that to always get them private and alone. That's great advice, you guys. We're gonna end this shortly. I thank you as always. Again, their tool is on our website. We will repost that again. But all of our information can be found on our resources. If you need technical assistance, please use the QR code. Substance use, remember, is the only medical condition that is also a crime. And, we always like to remind and put some realness to this. We are on social media, Facebook, Twitter. Here's my information, and I am going to go back. There is some information for, we had Triveni, information. There it is. I'm like, I lost it. Okay. If you have any questions, again, we thank you so much. This is an honor to have you here with us. Again, they are the authors, and we put trauma-informed care for opioid use disorder for our navigators. It is on our website. And we will have our next Navigator update. And the link is in the chat. And remember, addiction is not a moral failing. It is a chronic disease that requires medical treatment. These are our pearls, and we just want to make sure that you guys, feel supported. These trainings, make sure we have your correct email, because we will send out the eval to you on email. Please fill it out, put your suggestions. If you want more trainings like this, if they're helpful, let us know. We really try to have speakers that you guys want to hear. And this was definitely one of them. Learned so much. This is great. And I love the fact that we talked about motivational interviewing too, because that's been our key point. Thank you. Any final words? Dr. DeFries, Dr. Machtinger?
Thank you all. I've learned a lot from you in the chat.
Yeah, I really, really appreciate you welcoming us into your community, and we're here for you in any way. And our emails are part of the slide deck. Look forward to more similar meetings, and maybe even meeting in person someday.
Absolutely, yeah, that would be great. And again, thank you. And until next time, you guys, we will send out the eval and a follow-up email to all of you with more information. Great. Yes, in person. I think everybody wants to do that. Definitely. Thanks, guys. Have a great rest of the day. Thanks for attending. Bye.
Bye. Thank you.